All right, today we're going inside one of the most intense, high-stakes environments in all of medicine, the neurological emergency. This is a real race against the clock, where every single second counts towards saving the brain. So let's dive in and see how it's done.
Yeah, it's a terrifying thought, right? The brain, the very thing that makes you you, is suddenly in crisis. The response has to be lightning fast, super precise, and totally systematic. Because in this world, time isn't just money, time is brain, literally.
So picture this. A patient comes in with some kind of trauma. Those first few moments are absolutely everything. And it doesn't matter if it was a car crash or a fall, the initial approach is always the same. It's a universal game plan designed to stabilize and find life-threatening problems, like right now.
And that game plan is the primary survey. You might have heard of it as A, B, C, D, E. So airway, breathing, and circulation, they always come first. I mean, you can't have a working brain without a beating heart and oxygen, right? But it's that D for disability. That's where the neuroinvestigation really kicks off. It's the first quick snapshot of the brain's status.
This idea is known as the golden hour. And trust me, that's not just a dramatic phrase for TV, it's a clinical reality. The care a patient gets in that first hour can literally spell the difference between life, death, or a lifetime of disability. The pressure is just immense. Okay, so once the ABCs are stable, the focus narrows and it gets laser sharp, right on the brain. The team needs to figure out what's going on inside that skull, and they need to know fast. But how do you assess an organ you can't even see? Well, you learn to decode its signals. And the number one most important signal is the level of consciousness, or LOC for short. Before any fancy scan, before any complex test, a change in a patient's awareness, going from alert to maybe a bit confused to drowsy, that is the very first, most sensitive warning sign that something inside the brain is going very wrong.
So how in the world do you measure something as tricky as consciousness? Especially in a chaotic emergency room, you need it to be objective. The answer is a standardized tool, and for decades, the gold standard has been the Glasgow Coma Scale, or GCS.
You know, the power of the GCS is really its simplicity. In just a few seconds, a nurse can check three key things. Are their eyes opening? What's their verbal response like? And what about their motor response? Each one gets a score, and you add it all up for a total out of 15. That single number gives a super quick, reliable snapshot of brain function that anyone on the medical team can understand in an instant. And that number has huge implications. A GCS score of 8 or less isn't just a low number. That is the clinical definition of a coma. It's the critical line in the sand that tells the team the brain injury is severe, and they probably need to take over the patient's breathing right away. Now, let's see how this whole race against time applies to one of the most common and feared neurological emergencies out there, a stroke. In this world, there is absolutely nothing with a tighter deadline. This is the mantra. This is the absolute law of stroke care. Every single minute that blood flow is cut off from a part of the brain, millions of neurons die. And they don't grow back. So the clock isn't just a factor here. The clock is the enemy.
Okay, this is so important. Not all strokes are the same. You've got ischemic strokes. That's a blockage. Think of a clog in a pipe. And you've got hemorrhagic strokes. That's a bleed, like a pipe bursting. And their treatments are complete opposites. Giving a clot-busting drug for a blockage would be absolutely catastrophic for a bleed. And that's why an immediate CT scan to tell them apart is the most critical first move.
And this part right here, this applies to every single one of us. The FAST acronym is the single most powerful tool for recognizing a stroke out in the world. Face drooping, arm weakness, speech difficulty. If you see any of these signs, it is time to call 911. Recognizing these signs early is literally the first lap in that race against time.
So beyond stroke, the emergency department is a battleground against a whole bunch of other neurological threats, from dangerous pressure building inside the skull to the terrifying electrical storm of a seizure.
See, your skull is a fixed bony box. It can't expand, so when the brain swells up from an injury or a bleed, the pressure inside, that's the intracranial pressure or ICP, it starts to climb. Think of it like a pressure cooker with no safety valve. Normal pressure is between 5 and 15. Anything higher than that starts to literally crush the brain.
And the progression of rising ICP is just deadly. You know, the early signs can be pretty subtle. A headache that just keeps getting worse, a little more confusion. But the late signs, they're catastrophic. There's a pattern called Cushing's triad. That's high blood pressure,
with a plunging heart rate and breathing rate. It's the brain's final screaming alarm that's about to herniate or shift, which is almost always fatal. Now, during an active seizure, the priorities shift completely to safety and airway. The number one thing to do is turn the patient on their side. That keeps them from choking. You protect them from their environment, move stuff out of the way, but you never ever hold them down. And crucially, you time it. Because a seizure that goes on for more than 5 minutes is a massive medical emergency called status epilepticus. So you're faced with all of these terrifying threats. What can you actually do? Let's take a look inside the toolkit that nurses and doctors use to fight back and protect the brain. For managing that super dangerous intracranial pressure, nurses use the press mnemonic. It's a simple playbook for some really complex care. You position the head up to help the fluid drain. You manage their respiratory status very carefully. You keep the environment calm and quiet, and you have seizure precautions ready. Every single one of those actions is designed to bring that pressure down. And of course, there are some really powerful medications. TPA is that famous clot buster for ischemic stroke, but its power is tied to that incredibly tight 3 to 4.5 hour window. Mannitol is this amazing diuretic that literally pulls swelling out of the brain tissue. And lorazepam is a fast-acting drug used to break a seizure in its tracks. So whether it's positioning a patient, giving a medication, or just carefully monitoring them, every single thing we've talked about comes back to this one central mission: to protect and preserve as much brain function as humanly possible. So, after all of this, what is the single most important thing for you to take away from this? It's this: remember FAST. Face drooping, arm weakness, speech difficulty, and time to call 911. Knowing this doesn't just make you informed, it makes you a potential lifesaver. You could be the very first link in that chain of survival. And that really leaves us with a final question. The race to save a brain, it doesn't always start in an ambulance or in the ER. A lot of the time, it starts with a bystander, a family member, a friend. So after everything we've gone over, in that moment of crisis, could that person be you?